So there is a differences between myth versus fact. Myth is methylene blue cause analgesia with its neurolytic actions, but after reading the literature I found that it is neurotropic. There's no evidence of neurolysis, at least with the information we have at this point. But the question is, does it really have any neurolytic property? I was interested to investigate this question since our lab has extensive experience in investigating neurolytic effect of any drug. We recently published a paper in European Journal of Pain where we gave capsaicin, infiltrated capsaicin in the skin before making surgical incision. As you see here, before giving capsaicin, the nice epidermal nerve fiber we see in the here, and after capsaicin, these fibers are completely gone. So when in denervated skin, if you make incision, obviously there will not be any pain. And this is what we found here. As you see that spontaneous pain-like behavior significantly attenuated by after infiltration of the capsaicin. Also, there is a decreased pain behavior in the evoked pain behavior by the heat and mechanical stimulation. So you might ask here, why then we don't use capsaicin for incisional pain or postoperative pain? And to answer this question, I must tell you that denervation is not a good mechanism, good way to control pain, except the cancer pain. Cancer pain, when life expectancy is short, it is okay to use neurolysis. But other non-cancer pain, it is better not to denervate nerve, because we need this nerve for other purposes. Like this nerve secretes neuropeptide, which is extremely important for the wound healing. Also, the capsaicin itself can be very painful. So overall, although it has significance in basic science research, but clinically it is not that useful. So we did exactly the same protocol to determine analgesic property or neurolytic property of methylene blue. So what we did here, we exactly the same way, we infiltrated rat's paw with methylene blue. And then we took the skin biopsy to check epidermal nerve fiber density and pain behaviors. And usually these studies are done similar fashion as clinical trial, like randomized and blinding. Investigator was blinded to the what kind of drug was given. But in this, you see the intense staining of methylene blue, and it's harder to blind the investigator. After looking at the skin biopsy, we see that we didn't quantify, but it looks like fibers are decreased. Quantity number of fiber decreased. We got excited that maybe this is what we are looking for, and it caused neurolysis, and maybe that's the mechanism for other studies for analgesic effect. But we must show some pain behavior that is neurolytic property affecting the pain behaviors. Then I tested the heat pain behavior, and this pain behavior I and my colleagues characterized in 2013, which was published in Journal of Neuroscience Methods. So in this technique, we at first place the thermal probe, which is input to the feedback control system, just underneath the rat's paw. Then we use radiant heat from lower to higher intensity to identify the threshold. So with this technique, we found that methylene blue 0.1% and 0.1% or saline, there's no difference in the threshold. But when you use methylene blue 1%, instead of analgesia, we see hyperalgesia. The threshold decreased, and it lasted up to 9 days. Although here is we don't find statistical significance, but at 2 hours it is statistically significant. this is a great disappointment for us, because we got some neurolytic property looks like, but it caused instead of analgesia, and we found hyperalgesia. We tested another pain behavior, which is called mechanical pain. So in this technique, we used mechanical force from lower to higher intensity underneath the rat's paw to identify the threshold for withdrawal behavior. And we found that almost no differences between these three different concentrations of methylene blue we used in saline treated rats. So you might ask here, why heat stimulation produces differences but not mechanical. And I think if you look at the techniques, in heat stimulation we produce very diffuse radiant heat, which involve the rods area of the skin. So maybe it recruited a lot of nerve fibers. Then the mechanical stimulation, which focused on very tiny area of the skin. And then we did another experiments on these rats. It's called spontaneous pain behavior. So my undergrad student, Mr. Kavardi, who is now internal medicine specialist in VCU, and myself described this technique in 2015. With this technique, we don't stimulate the rats with any heat or mechanical stimulation. We just, after making any pain model, incisional pain or something else, we look at their just behavior, watch their behavior for 20 minutes to 1 hour, and see their flinching behavior or withdrawal behavior, and count them and compare them with the saline treated rats. And we found no differences with methylene blue or the methylene blue applications between saline and treated animals. So but during this testing, we found that some rats developed swelling. We said, well, let's quantify the swelling. So we use this technique described in this journal, and it's a very simple technique. It's just a beaker of water, and we immerse the rat's paw to check the volume of the paw, and which can be measured with any scale. We found that there is significant paw edema in the 1% methylene blue, which is correlating with the heat hyperalgesia we found earlier in the same concentration, and it is significant in the 2 hours and 1 day after injections. And but there's no difference between 0.1% and 0.01% of the methylene blue. This results again very surprising, because we are looking for analgesia, we're looking for neurolysis, but all we are getting the swelling, heat hyperalgesia. Anyway, paw swelling kind of give us the impression that maybe there is an inflammatory reaction going on. So to check the inflammation, as you know that what do we do? We check the WBC count, we check the ESR, SED rate, or CRP, and we can also check the skin biopsy, which you see the inflammatory cell infiltration. So this is exactly what we did. We took the small skin and from the control and methylene blue. As you see here, the intense inflammatory infiltrate around the perivascular infiltrate in the methylene blue treated animals, which suggests that inflammatory reaction. Overall result is surprising. That's unexpected. We, as I said, we wanted analgesic action, because that has been shown in other studies in the pain in case series, not study, but in case series and case reports. And these results doesn't fit with those report. And it's a surprise. And life is full of surprises. Some good, some not so good. So, but someone said great discoveries often come from unexpected results rather than hypothesis-led research. I was still struggling to understand this drug in the market for 20 years. It is listed as a most essential medication by the WHO. It is in a clinical trial for almost like 20 different drugs. 20 different disease. And is a lot of clinical case report or case series reported improve pain with methylene blue infiltration and methylene blue injection. So how come no one ever noticed that there is any inflammatory reactions, that it may be edema? And I thought maybe we are wrong, maybe we use a contaminated methylene blue or something. And so then I was searching for the literature. So, now these days very hard to publish case report or even case series, but they are very useful for finding the rare complication. So this paper showed that it is a skin and fat necrosis of the breast following methylene blue dye injections for sentinel node biopsy. And they did not mention of the concentration of the methylene blue. In our study, less than 0.1% did not show any inflammatory reaction. But another study presented here, so 6 case series of inherited local inflammation to tissue necrosis in breast after methylene blue infiltration. Here they mentioned concentration. It is 1%, which is exactly what we used. Another study, skin flap necrosis by bone marking with methylene blue in cochlear implantation, did not mention the concentration. Several studies showed swelling of the hand after IV infiltrated when the patient was getting methylene blue infusion. Concentration 1%, exactly the same concentration used. So we are convinced that it is not our bad study or something. It is from the clinical report. It must be there are some inflammatory reactions, and combining this our clinical study and basic science research, I think it's fair to conclude the cutaneous infiltration of 1% methylene blue causes foreign body reactions, inflammation, and heat hyperalgesia. The next, as you showed you before, that it does have some chemical ablation or neurolytic properties after cutic skin infiltration. So, but skin is a very heterogeneous structure. We do not know if it has a direct effect of methylene blue on the nerve or just a consequence of the inflammation. So we decided to do study on the isolated neuron, and we picked up the dorsal root ganglion neuron because it's 100% sensory neuron. And if you take this neuron and grow them in the petri dish, they develop this kind of nice tails, beautiful tails, and their soma get bigger, and they developed processes. As you see in these control conditions, a lot of cells have processes except this one. But you apply methylene blue, cell soma size gets smaller, and almost no processes in any of the cells. So it's definitely toxic to the cells, neuronal cells. We are trying to identify now the LD50, and this is a work in progress. We are still working on it. LD50 of this drug. This is another example, nice processes in the control conditions, and again, no processes in any of the cells in the methylene blue treated cells. And you might not be convinced at this point it causes neurotoxicity because it is in vitro condition. To make you more convinced, there are some studies, there is some case report of quadriplegia and even spinal cord necrosis after intrathecal administration of methylene blue. And I think Mike Todd is here, and he can tell you methylene blue used neurosurgeons used methylene blue before to identify the dural lake. Let's say someone come with rhinorrhea or any other conditions, then they identify the dural lake with methylene blue intrathecal administration, and then you see several case report are quadriplegia and paraplegia. So I think this is very convincing to